Next speaker is Dr. Abhishek Kumar, who is the consultant critical care Apex Hospital, uh, Jalandhar, India, and he will talk on antibiotics and nutrition. So, welcome, Dr. Abhishek Kumar.
I really appreciate Dr. Ranjit and Dr. Shah for giving me an opportunity to speak on a topic which is slightly different from CRRT but very close to intensive care unit with CRRT. So I changed the topic a little bit, antibiotic and nutrition with CRRT. I hope it's okay, Dr. Ranjit. So if you see how we prescribe antibiotic, particularly in case of intensive care unit, sick patient, and API patient. General prescriptions which coming as a prescription index in the package insert of an antibiotic is based on the therapeutic index. That is the median therapeutic effect where toxic effect we take out and find the therapeutic index. And this is the most common way of prescribing our antibiotic in AKI patient. Second is second thing is that we calculate EGFR and prescribe that medication according to the calculated GFR of the API patient. But question changes when CRRT or any other replacement, renal replacement therapy is introduced because it causes change in pharmacokinetics and dynamics of the drug because of the CRRT factor, membrane factor, drug characteristic, and ever-changing volume status of the patient, as well as the clinical condition. So it has been addressed that antibiotic therapy which we are giving to our patients who are on CRRT does not go with the normal doses which we give. So they need meticulous attention and reassessment. Empiric antibiotic therapy for CRRT patients is not suitable. So we need to calculate the other factors to prevent toxicity because of overdosing, as well as same time treatment failure we want to prevent because of the underdosing of the antibiotic. In this, for proper dose calculation, we need to consider CRRT factors, which our renal therapy, renal replacement therapy is going to induce. Second, patient individual condition and the drug which we are prescribing its own pharmacokinetics and pharmacodynamics. We have seen in last 10 years that antibiotic therapy has got changed from boluses to continuous infusions and extended infusions. Some drugs you give in a higher bolus and long duration action, so their dosing regime has been changed. All these things are there, but when we talk about CRRT and antibiotic, it is the type of modality of CRRT we are using that's described along with effluent. We'll discuss it later, but my job has been done easy by Dr. Vivek and Dr. Ranjit a lot. We know by the now that hemodialysis, hemofiltration, and hemodiafiltration, these are the three main techniques which replaces most of the molecules of low and medium size if we combine. So the drugs which are generally antibiotics, antifungals, and antivirals, they generally have their molecular weight between 5,000 to 1,000 Daltons. Bigger molecules, more than 1,000 Daltons, can also be removed by hemodiafiltration because of the condition. Second thing is we take into consideration of CRRT membrane. As Dr. Vivek told you very nicely that sieving coefficient and saturation coefficient, these two things we consider if sieving coefficient or saturation coefficient is zero, no drug can pass through membrane, and if it is one, all the drug will pass through. So which drug reacts with which type of membrane, that is also taken into consideration while we are dealing with dosing of antimicrobials on CRRT. If we see the type of filters or type of membranes like polysulfone, methyl methacrylate, and acryl nitride, various type of filters are available, but there are no guidelines, no literature support is available in particularly for antimicrobials which are absorbed on CRRT membrane. So we don't consider them into the dosing regime. Along with this, there is a one more thing that is a residual renal function or ever changing renal function of native kidney because it is changing with time because it's not a chronic renal disease, it's a acute renal disease and the volume of distribution which is changing because of that. Apart from that, dilution method we are using in our pump, pre-pump dilution or pre-dilution or post-dilution, that also changes the kinetics of antibiotics because pre-dilution reduces membrane presentation of antibiotics, so the removal is less. And if we do post-dilution, then the removal of antibiotic is more because undiluted plasma is directly exposed to the membrane, so more drug is removed. So again, the type of dialysis, pre-dilution and post-dilution is the key factor for making a effluent flow rate, which is a sum of dilute and ultrafiltrate rate. And this is considered as the most important parameter for deciding an antimicrobial dose in CRRT patients. CADICO has given a guidelines that 20 to 25 ml per kg per hour effluent rate is considered as adequate, though the various other higher doses and were are also used as discussed by Dr. Ranjit. So I'm not going into detail, but most of the guidelines and most of the antibiotic prescriptions they are based on 20 to 25 ml per kg per hour of CRT received by the patient. It is still important and necessary to consider effluent flow rate of CRRT for antimicrobial dosing strategy. These are the CRRT dependent parameters which we have to consider for prescribing an antibiotic dosing. Now, second comes the physiological property of our antimicrobial agent which guides. There are two type of antimicrobials. First are hydrophilic, though, and second are lipophilic. Lipophilic antimicrobials generally have a larger volume of distribution, and hydrophilic they have a lesser volume of different distribution, and they are cleared by the kidney. Lipophilic were cleared by the hepatic or extrahepatic tissues. In sepsis also, we differentiate according to the hydrophilic character of antibiotic or lipophilic character of the antibiotic, whether the need of loading, increased dosing dose is there and maintenance is by continuous infusion for hydrophilic drugs and same is and but in lipophilic drugs we need not to change the dose and same is true for when we are using the CRRT infusion. If we see the kill characteristic of antibiotics, it could be time dependent. That means the concentration of antibiotic is above MIC for longer duration. Then antibiotic is most accurately acting to kill the bacteria. Second is the concentration dependent that a particular concentration has to be achieved to kill a bacteria. It is not dependent for how long it is. And third type of antibiotics are concentration dependent along with the time dependency. That means the concentration is peaked for how much time in 24 hours. If we see on the curve of drug dose and time curve, concentration and time curve, you see if the peak concentration is reached and that causes the killing of bacteria, then the antibiotic is concentration dependent. And this single dosing and adjustment as per CRRT modality is to be done not on the other side. If you see the concentration, that means area under the curve, is above the MIC for a longer duration of time, which is required for killing a bacteria like pseudochloronons, vancomycin, then you need to adjust the boluses and the time duration between the boluses, and the same thing has to be applied for the change in CRRT model. Third are the time dependent, in which we are using higher loading dose and a continuous infusion to maintain a certain concentration above the MIC for a longer duration of time. These drugs are the most difficult drugs to handle on CRRT because they has to be infused in a continuous infusion manner, and these drugs are, if having a low therapeutic index, then need therapeutic drug monitoring. So how we formulate the strategy during CRRT? So we know that the CRRT effluent flow rate is the main guide. Second, molecular weight of the drug, which is usually less than 1000 Dalton. Third, the volume of distribution and drug elimination pathway and protein binding of a drug is considered as the most important PK parameter of that drug, which is to be taken into consideration while deciding dose. Most antibiotic antimicrobial drugs have molecular weight less than 750, so they can be removed easily. Dosing of the CRRT modality and effluent rate is the most important parameter which decides the dosing. Drug binding protein, they are difficult to remove from the CRRT. So the drugs which are lipophilic need not any adjustment of the doses during CRRT. Most important thing is one size does not fit in all sizes. Even on CRRT, if you are using the empiric dosing, uh, you need to reconsider it because the physiology, pathophysiology, as well as dosing, as well as volume status, ever changing with slow replacement therapy. So we need to fine tune and adjust according to the patient. I was very much confused that which drug I need to give in what doses, particularly in when the CRRT on. My job was made easy by this paper which was published in 2020. It's a Chinese paper published in Pharmacology Journal by Luli. What they did, they analyzed the entire PKPD parameters along with molecular weight, protein binding, volume of distribution, pH of the drug, PKPD target which we want to use, and how they are excreted. And then they analyzed and formed a table in which they, they have given that these drugs need to be modified during CRRT treatment and these drugs do not. And for your ease, I'm giving you this table in front of you. The drug which needs adjustment are this much, and the drug do not require adjustment are. We made my job a little more easy by giving three tables. I think you should all have this table along with you while prescribing antibiotic on CRRT. Particular method of CRRT, like we are using CVBH, then particular antibiotic is going to have what dose at what ultraviolet. So this is given for CVBHD and CVBHDF also. And he formulated this by reviewing all the articles from 2010 to 2020. They were talking about dosing of antibiotics on various modalities of CR. And it is quite interesting to know that if you see the piperacillin tazobactam, if you see a AKI patient, there is a dose reduction according to the change of GFR. But if the patient is on CRRT, then the dosing is almost same as we are giving to a normal individual without kidney. So this much change is there when you are using CRRT, and when you are doing hemodiafiltration, then the doses are actually more than what we are prescribing in our patients who are not having it. So this is for there. For amikacin, if you see, the dosing duration is 40 liters, but the dose is little higher, 25 mg. So for different modalities, you are using different, because the amikacin is a kind of a drug which kills the bacteria by concentration. And the same way, if you see the polymyxin do not have any change required while CRRT, so relatively stable. The same time, if we are using colistin, then depending upon CRRT modality and your effluent rate or dialysate rate, then loading as well as maintenance are different, and they are as close as your normal dose of colistin in non-steroid. But if you are using again CVPHD, hemodiafiltration, then the dose is are literally higher to 12 million units per day. Therapeutic drug monitoring, yes, it's a very good tool. It helps when particularly agents like vancomycin, those who are having a narrow therapeutic index, you can use it. But various problems with therapeutic drug monitoring program, particularly when it was seen with beta-lactam, there are various problems like clinical advantages are not clear. Technique require expertise as well as uses has to be made according to the institutional need. Third, turnaround time, then most important, the cost, whether it is cost effective or empiric dose adjustment according to the various literature supports are overweighing our therapeutic drug monitoring system. It is not clear. So it is useful only when there is a patient who is requiring a more careful monitoring, as well as you are more worried about the toxicities and the therapeutic index of that particular drug. Coming back to the second part of my discussion, that is the nutrition with CRRT. Look, in AKI patient, like any other patient who is seriously or critically ill, there are three phases: early phase, acute phase, late phase, and then comes the anabolic phase. In early catabolic phases, the nutritional requirements are there, but body is not ready to utilize nutritional substances. So we go slow in this, and we go fast in this area because we want to prevent chronic malnutrition or chronic catabolic syndrome. So shifting of patient from this to this, most of the time here the CRRT is being used at between 3 to 7 days. So at this particular time, the transition from CRRT to conversion to anabolic phase of the patient, at that time, particularly the need of nutrition support. The various things which are associated with ARF, particularly metabolic syndrome, protein catabolism is a known thing which is happening, particularly specific amino acids which are altered metabolism like lysine and other amino acids. You have to be careful. Insulin resistance is there in AKI, that is also known phenomena. Reduction of lipolysis, fat clearance is there, that is also known. Along with this immunodeficiency, pro-inflammatory states, with all these conditions which are there and can be taken up with by various other elements, but that is standard with all critically ill patients and nothing specific related to the CRRT itself. The things which are related to the CRRT in planning of your nutrition and uh, fluid balance is that your fluid balance, as discussed by Dr. Ranjit also, that your fluid balance should have a space for your parenteral as well as enteral support. which generally we miss out while we are prescribing our dialysis. This is a request which I want to make to every person who is doing the dialysis in ICU, that you should have that particular volume which are required to make your calorie need of the patient should be calculated in your dosing of CRRT. The type of filter is again not going to decide which type of amino acid is going to filter, or which type of protein is going to be lost from filter, but definitely there is a loss of amino acids in ultrafiltrate. So we need to supplement with that in a way that 10 to 15 grams of amino acids per day is loss of CRRT. We need to take care. No change in lipid loss, no need to change the lipids, particularly if patient is on CRRT. We go with the same lipid formulation as we go for other critically ill patients. Lactate, hyperlipidemia, metabolic alkalosis, these are the things which are present, the citrate toxicity and all these things. I'm not going into detail. If they are this, they can be potentiated if you're not going to give a particular attention towards these. Again, hypophosphatemia, hypomagnesemia become more pronounced if refeeding syndrome is there with supplementation of parenteral nutrition on CRRT, so you have to be careful. A big question comes on CRRT, is there any difference for going for parenteral nutrition or enteral nutrition? The golden rule is clear by ESPN guidelines that only use parenteral nutrition if your goals of calories are not met through GI tract, or your GI tract is not available for the nutrition to be taken up for the body. So the parenteral nutrition can be used, but only if your GI tract is not available, and there is, as such, there is no role of parenteral nutrition in CRRT because of calorie requirement, glucose requirement, fat requirement, protein requirements are almost the same. The ranges shows the important thing has to be looking at that it should be calculated on the ideal body weight, not on the patient's original body. Because volume status changes frequently in AKI patients and in patients on CRRT. So you need to calculate energy, glucose, fat, protein, everything on the ideal body weight, not on the original. Phosphate, potassium, and sodium need consideration, along with microelements, particularly water soluble vitamins and fat soluble vitamins E and K. They need replacement, and daily replacement are mentioned in all type of literature. You can get it from it. Supplementation of vitamin A is generally not required, so don't pay attention to that. With these words, I really want to conclude my lecture saying that more calculation is required when the patient is on CRRT, not only for the CRRT dosing, but also for other things also, like antimicrobials, antifungal, antivirals we are prescribing, as well as the nutrition you are planning for your patient. So for that, you need to consider the residual renal function or developing residual renal function on therapy. Then consider PK/PD parameters, CRRT modality which you are using, effluent flow rate, and to guide this empiric doses, your ready retinal tables are going to be helpful for you. Keep them along with you and prescribe your antibiotics judicially so that the effective bacterial killing should be there and there should not be more toxicities which are associated with antibiotics. Therapeutic drug monitoring is suggested only for those when your empiric therapy are producing more toxicities or the therapeutic window of particular drug is very narrow. Nutrition support, you need to take care of both macro and micronutrients, but it is not different from other critical when patient is on CRRT, but dosing of CRRT should consider the space for nutritional volume which you want to give enterally or parenterally. Parental nutrition does not have any specific space or upper edge above the enteral nutrition. This is only indication when your gut is not available for your nutrition. With these words, really want to thank again and giving me opportunity to speak something. Thank you.
Thank
Over
you,
to
Dr.
you.
Abhishek. Thank you. Thank you, Dr. Abhishek, for such a uh, precise and crisp description, because this is a not so easy topic. So just one or two comments about antibiotics, because just to sum it up again, that hydrophilic drugs with limited volume of distribution and small protein binding are cleared during CRRT. And
True.
it is the loading dose should never be compromised. Whatever may be the loading dose, never compromise with the loading dose. If at all the dose has to be changed or reduced, it is the maintenance dose, either the dose or the duration. Remember, if the anuric maintenance dose, if there is the patient is in anuric, the anuric maintenance dose should be increased if your filtration fraction is also increased.
Yes.
If you're increasing your filtration fraction, if you're increasing your ultrafiltrate rate, you have to increase your maintenance dose. Also, during the nutrition, as Dr. Abhishek has correctly said,
There is
normally
an
we normally compromise with the proteins. We should not compromise with the proteins. The proteins may be given a bit high, up to 1.7 gram per kg per day. So this has to be remembered. I quickly move on to the, because